Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. We're so happy to see everyone here. For anybody watching who might not know who I am, I'm Danielle Hicks, Chief Patient Officer here at GoTo for Lung Cancer and the moderator for this programming. Our Living Room Expert Speaker Series is really intended to bring to you live and in real time information about lung cancer across the care continuum. So whether you're at risk or newly diagnosed, or if you've been living with lung cancer for a long time, we hope to bring to you updated information in real time with expert speakers. So tonight we're going to be talking about Lung Cancer 101. So it's really taking a step back from any one point of care or treatment or diagnostic when it comes to lung cancer, and really talking at a higher level about lung cancer in general, and what good looks like from diagnosis through proper upfront treatment and then survivorship. And we have our very own friend down the street, Dr. Neal from Stanford, who's no stranger to the living room. He has been a speaker here before, and we absolutely adore having him come in and have these conversations with us. So let's get serious for a second. Lung cancer is a complex disease. I remember back in 2003 when my own mom, Bonnie Adario, was diagnosed, there was sort of a one-size-fits-all approach outside of clinical trials, where some of these things that we're going to talk about tonight were still in the early days of it. But in the last 21, 22, 23 years or so, so much has changed. And I think you guys have all heard me say before, because of the complexity of a lung cancer diagnosis, it's really important that you're being treated by somebody who knows what's going on right now, not just even what was going on a month ago, because there's a high likelihood that even that has changed. That's how fast and furious things are happening. And so I also think that before we jump into an actual diagnosis, I'd like to touch on early detection a little bit. I always think it's so important. And I know those of you, the majority of you watching tonight, or who will come back and watch this post live, have already been diagnosed, and that's what you're looking for, and we're going to get to that. But I also think you all, not solely, but you all are an integral part of spreading the word about screening and early detection. We all know somebody who would qualify for this potentially life-saving diagnostic. And sadly, in the United States today, less than 10% of the people that qualify are actually getting screened. So, Joel, can we talk a little bit about the screening guidelines, who qualifies, and help to educate our viewers on who they should be talking to?
Historically, we've always thought about the idea of using chest x-rays or CTs when CT technology became better to look for nodules in the lungs. One thing about lung cancer is we don't have any nerves in the middle of our lungs, so we can't really feel a mass there, and we don't have any symptoms. It's relatively unusual to have a cough or a small mass, or be coughing up blood, or have really any symptoms whatsoever. So these nodules really can be silent. And in people with a history of smoking, clearly we know that they're at a higher risk for developing lung cancer, and particularly with a 30-pack year smoking history, and within the last 10 to 15 years or so. So the guidelines, there was a big screening trial actually comparing chest x-ray to CT scan, and demonstrated a survival benefit with low-dose CT scans, which use a little bit less radiation than the traditional CT scans of the time, although I think all CT scans are now lower dose than the low dose was back then, because our detectors get better and better. But for patients with a history of smoking, and put within the last 10 to 15 years or so, ages, I think it's 50 to around 80 right now is what the current guidelines are, but we've been continuing to expand those guidelines. And really, without symptoms is the key. For anybody with symptoms, they can get a CT scan anyway. Without symptoms, there is an indication for annual low-dose CT screening. I'll note that we've actually looked into the database of some of the research that we've done at Stanford, trying to figure out, are those guidelines applicable to everybody? And we found that, more than the total pack years of smoking, so 20 to 30 pack years is where the risk really goes up. More than the total pack years of smoking, the duration of entire smoking matters too. So if somebody smoked half a pack a day, but for 20 years, that may be only 10 pack years, but actually that duration is a higher risk also. And when we start to look at the duration of pack years, as opposed to just the total number of pack years, we incorporate a lot of patients who might not otherwise qualify, particularly those from underserved communities, actually. They might have had a more sporadic smoking kind of pattern than a very consistent heavy pack use. So, we're now looking at maybe modifying the guidelines yet again. So certainly for people with a history of smoking, think about the guidelines, talk to your doctor.
Yeah, absolutely. And I obviously won't speak for you, but I will speak for myself. I won't even speak for GoTo when I say that I don't think it's enough. I think it's something. We fought really hard for decades to get lung cancer screening to even be a thing. And we've been here now for several years. And ACS, for example, just put out a lot of their new statistics. And we know that lung cancer is, declining in men, but it's increasing in women. Why? We need to know why. And never smoking women. It also happens in never smoking men, so I don't want to discriminate there. And, although I recognize the fact that smoking a smoking history puts someone at high risk, it's not the only thing that puts somebody at potential high risk. We just don't know enough, right? So when we think about exposures to chemicals, we think about our veterans in the burn pits, we think about our first responders, like we saw them all in Los Angeles just this last week, and all of these things that they're ingesting, we need to dig deeper. We think about radon, which is just a natural gas emitting from the ground. That's also the second biggest risk factor. We get calls all the time asking, well, what about me? I don't fit this criteria, right? Or I quit smoking 20 years ago, and these guidelines say I can't have quit smoking more than 15. In fact, the ACS just last year, I think 12, 18 months ago, came out with a new recommendation saying, let's get rid of that 15-year quit data point or whatever, and let's just screen anybody who has a smoking history. The USPSTF has yet to kind of come on board with that, the United States Preventative Services Task Force, but we're fighting hard to open that up. So enough said about that. I will get off of my soapbox and my frustration. There are other things available. I'm happy to talk to people about it. Other things coming down the pike, such as blood tests and the like, but those also come with their own sets of challenges, and is probably a living room all on its own.
I might reinforce, though, that there is something to the risk factor of certain demographics, right?
Yeah.
Even without known exposures of pollution or radon or secondhand smoking or things like that. And a number of countries have done studies of Asian women never smokers and done screening, and they often find little nodules, generally kind of less aggressive, more like polyps of the lung, I think about them. Little tiny nodules, as opposed to more aggressive lung cancers that we find in people with a more recent smoking history. But we are moving and thinking about efforts, especially in the Bay Area, where there are lots of women Asian people without a smoking history, and thinking about ways to incorporate them or at least do clinical trials of screening tests. But the number of patients, even the ones who are eligible, who are either not being offered low-dose screening who qualify, or maybe declining it, we don't know how that works exactly. It's quite a few. So, the uptake overall of screening is maybe 10% of the people who qualify, right?
Yep.
And that's a huge opportunity right now.
Yeah, I agree. It's like I said, I think 16 million people if you get rid of that 15-year quit date. I think I've talked to you all before about a study that's being done right now, because people quite often ask about inherited lung cancer. Is lung cancer an inheritable disease? And GoTo, Alchemy, the Adair Lung Cancer Medical Institute in Dana-Farber are conducting sort of part 2 of an inherit study looking to try to identify what we refer to as like germline mutations. Is it something that you're born with? I'm a part of this study, and I know I have a huge interest in this when I look at, although it began with, for me personally, what, at least as far as I knew, my mom's diagnosis, come to find her grandfather, her mother's brother and sister, and my mom, so all on the maternal side, were diagnosed with lung cancer. Some of them smoked, some of them didn't. So what does that mean? What does that look like, right? So I'm interested not just selfishly for myself, but my children and my grandchildren, and how might that look down the line? And I know a lot of you feel the same way, because it's a question we get all the time.
I'll point out too, locally as well, in addition to the collaboration and the Inherit study, there's a study called the FANS study, FANS,
Yeah.
that's being run through UCSF, right?
Yep.
Is that the same, or is that?
It's a completely separate study, but similar in nature. It's just in the Asian population, right? So,
Yep.
yeah.
Female, Asian, never
Yep.
smoker, they put it in the name, so I
Yep.
can say those words.
Yep. Yep.
And you can look for FANS, and UCSF and Stanford's a partner with that too. Trying to figure out what are those genetic risk factors, because lung cancer, we can find an EGFR mutation, but that's not the risk factor for the lung cancer with a mutation. The risk factors, we need tens of thousands of patients, volunteers, to say, hey, you and your family, can we figure out what's contributing to this?
Yeah, absolutely. And the folks who are regulars at this programming know that I'm a huge proponent and constantly encouraging people to look into different studies like this. Not all clinical trials or studies are treatment necessarily related. So there's definitely opportunities to engage in that way. So I'm just going to walk through really quickly, because in spite of the fact that screening has been available for 10, 12 years, it's been available for a long time. We still have a lot of work to do there. And so most people are still diagnosed at later stages. And so quite often, people are like, what are their symptoms? I mean, lung cancer is very silent until it's not. And once it's not, it's usually at an advanced stage. But some of the things to look out for: coughs that don't go away, blood in your sputum or your spit, like you're coughing and there's blood there, shortness of breath, wheezing, loss of appetite and weight loss, pain in the chest, back, and shoulder, which I don't think is one that people think of very often. I know it was my mom's number one complaint. That was the only thing she had, and they thought she was having a heart attack, and she had a pinched nerve and all the things, right? So we have an exhaustive list on our website for anybody who's interested to going in and looking more deeply into that. But I want to focus now on the diagnostic process. So let's assume you're either eligible for screening and you've gotten screened and something's suspicious, or you're a later stage, you've gone in, you've had a CT, something's suspicious. Joel, what does good look like once something has been identified and we need to take a deeper look to see what is going on?
The first thing to keep in mind is a lot of things we see on CT scans are not lung cancer. I get a lot of emails often from friends of friends or other people, and there's this little thing on the CT scan, and who knows what it is or why the CT was done. But there's some size thresholds. So, under 5 millimeters, something solid, or, under about 10 millimeters ground glass, we usually say, it's very nonspecific, let's not worry about it, let's just do another CT and don't stick a needle into it. Once they get solid, or if there's a change over time, then we start to worry a little bit more, especially with that change over time, because that can be a sign of cancer. Cancer grows and doesn't disappear. Infections stay the same if there's residual history of infection, or goes away. So then biopsy methods, we think about how do we approach that. If we think that something's suspicious, and there are very much lung cancer nodule guidelines that can be followed here, so we don't need to go into the details. But if there's a suspicious nodule, then there's a couple of options. One is needle biopsy from the outside through the chest. One is bronchoscopy-based biopsy from the inside, which technology is getting better and better to actually do a CT scan at the same time as the bronchoscopy. Get in there and freeze a spot and pull it out to actually get a chunk of tissue, not just sending small needles into it. And then the third option would be go straight to surgery. Every once in a while, somebody isn't strong enough to get a biopsy and it looks so suspicious for cancer that we'll say, okay, maybe we'll just radiate that thing. But for the most part, we want to diagnose it with a biopsy.
Yeah, and I think that's important to note, and you touched on it, the characteristics of the lesion or what it is that is being seen itself, because some characteristics are more indicative of a malignancy than others. So keep that in mind. And I think also, Drew, when I'm thinking even about your first doc, who might have said, and I don't know how big it was, and we don't need to go into that here right now, of course, I'm happy to talk to you about it after, might have just thought, oh, this maybe is a watch and wait thing because of what it looks like right now. So we get a biopsy. What are we looking for in that biopsy?
So ideally, the biopsy has a decent chunk of tissue. I talked about small needles put into things, or in the old days, they would actually do washings of the lungs. So they might find one tiny cluster of malignant cells. It's not really enough to tell us a lot. Maybe the pathologist would say suspicious for malignancy, but we need a piece of it to not only say it's cancer, which ultimately lung cancer is cancer, carcinoma in general, and we want to subtype it into both the major categories of cancer that can exist for lung cancer, as well as do all the molecular testing that we love to talk about. So the major categories of carcinoma, there's small cell lung cancer, which is about 10% of all lung cancers in the US, and going away because it's highly smoking associated. And then everything else, I always point out what a bad name it is, non-small cell lung cancer. You're like, why are we calling something what it isn't, right? Even though it's the majority. And then, even within non-small cell lung cancer, we have non-squamous non-small cell lung cancer, right? It's like, what's not and not?
Yeah.
What is it?
Yeah.
But the most common is adenocarcinoma, is what we tend to call it. That's non-small cell lung cancer and non-squamous tends to be adenocarcinoma, both in people with a smoking history and those without.
And I think it's important, to talk a little bit about why we're looking for type-specific information, right? Particularly when we're talking about the biomarker testing, which you touched on. Before we jump into the biomarker testing, we talk a lot here about both tissue and liquid biopsies. When I say liquid biopsies, can you explain to folks watching what that means and when it might be appropriate to use that technology?
Sure. So liquid biopsy basically means we draw one or a couple of tubes of blood and find something about it that gives us an assessment of what might be going on with the cancer. So there's different ways that you can use liquid biopsy in the treatment and even detection of cancer. So liquid biopsy, you can use them even when you know somebody doesn't have cancer. We sort of alluded to that, but they're not very sensitive because they are looking for things that might be associated with a cancer we don't know about. You can use them to look for a cancer that we know that somebody had, and see whether it's coming back in an ultrasensitive way. And you can use it to see more about their cancer. So basically, tumors, I like to think of lung cancers as a group of very unhealthy cells that just somehow makes a few more cells than die. So, lung cancers genetically are very messed up cancer cells, and a lot of cells are dying as the tumor is trying to grow very slowly. Those dying cells shed things into the blood, and then we can detect those things in the blood. And the main thing that we've learned how to detect, because it's very stable in the blood generally, is DNA. And so all the tumor gives up its DNA when it dies, and we can figure out what made up the genetic makeup of cancer. Keeping in mind that lung cancers and most cancers are caused by normal cells undergoing genetic alterations that make them grow abnormally and not die.
Yeah.
So we want to know what those genetic alterations are to try and characterize.
Yeah, I think that's important, especially when you think about, I'm going to give a shout out to Chef AJ. I don't know if anybody knows who she is, but she's got a YouTube channel. She's a, I don't know, lifelong, but 40-year long at least, vegetarian. And so she's got this very popular channel on YouTube. And she's recently gotten involved with cancer awareness. And I was on her show today, and it was fantastic. But one of the things we talked about is when people are diagnosed with cancer, especially those without any known risk factors, are like, why? Like, how does this happen, right? And I think it's some of the stuff that you just said, Joel, kind of explains. We had another doc in here. This was probably 15 years ago. His name is Jeff Oxnard, and somebody asked this very question. Like I think you two were here. Are you laughing? Yeah. So he was here and somebody was just like, I have no known risk factors. Like, how did this happen to me? And he looked this gentleman straight in the face and was just like, bad luck. I mean, literally, like, as blatant as that sounds, it's like you had a cell that went rogue or bad that your immune system did not find, and we're going to talk about this in a little bit, and your immune system didn't kill it off, and it landed somewhere, and sadly now you have cancer, and that's sort of the thing. And when we talk about immunotherapy, I think we'll talk about why that's an exciting place to kind of look. But while we're talking about biomarker testing, what are we looking for when it comes to biomarkers?
So beyond just the what flavor of cancer is this, which pathologists have been able to tell us under the microscope for 100 years,
Yeah.
All of those categories we talked about. We also want to know a little bit about the DNA makeup of the tumor and also a little bit about the protein makeup of the tumor. So the DNA makeup is sometimes we can find these genetic alterations, these DNA changes, that are the main switch that got turned on by accident inside the cancer cell that's programming it to grow and not die. So that we call an oncogene or an oncogenic driver or a driver mutation. There's lots of other mutations too. We talk about the big one because it's like pushing with the driver, but you also need the whole context of that. Sometimes people call it passengers or context, or it's ultimately the whole car put together that's going in the wrong direction, right? And just a driver pressing the gas, unless all of the car is turned on and the machinery is ready to go, isn't going to do anything. You can put a driver into a normal cell and the cell dies because the normal programs are like, this is not normal. But these drivers in the right context with the other right mutations are fueling the cancer. And those are things, we now have, I think, 11 actionable mutations that we look for in non-small cell lung cancer. I won't rattle them all off, but some of the more common ones that we all know about are EGFR, ALK, KRAS, smoking associated and non-smoking associated, we're making impacts in, ROS1, and many others. So we want to know the DNA makeup, and that you can find by liquid biopsy. You can also find it by the tumor itself. And then we also want to know something about the proteins. And the biggest protein that we look for is, you talked about immunotherapy. It's called PD-L1, and it's a shield protein that tumor cells can put around the tumor. And that shield, when the immune system comes in and tries to fight it, that shield basically says, nope, immune system, you shut down, you go away, nothing to see here. I call it like the Jedi mind trick. These are not the droids you're looking for, right?
Yeah.
So that shield is around the cancer, and the higher level of PD-L1 shield, the more likely the immune system's trying to fight the cancer, but being told to go away.
Yeah, that is absolutely fascinating to me. It's very similar to pregnancy. When a woman's pregnant, the reason that your body's not rejecting this foreign body that is not made up of just your DNA, but the father's DNA, by all rights, your body should be like, nope, this doesn't belong here. But a similar type shield comes, factors into place, and it tells your immune system there's nothing to see here. So it's the same kind of concept or idea, right? On a very basic,
Exactly.
I guess, level.
These are not the tumor cells you're looking for.
Yeah.
Right?
Yeah.
That shield to come up, if we take a step back, the shield comes up probably because the immune system was trying to fight the cancer, and the cancer evolved this defense to defend itself.
Yeah. I hate
so
saying
there has to be a pre-existing immune system trying to fight it, and then that shield blocking it for immunotherapy to work effectively, we think.
Yeah, it's crazy when you think about how, I'm not going to say how smart the cancer is, but how smart the body is, whether it's a good cell or a bad cell, right? And trying to defend its own self. Cancer is trying to defend its own self, no differently than your normal cells are trying to defend theirs with your immune system and everything else.
Yeah.
Yeah, it's nuts.
I like to think of cancers as not smart, right?
I know, same. Yeah, I know. So sticking with proper upfront diagnosis, so we know we need a biopsy to find out what type of cancer it is. We need this biomarker testing to find out what could potentially be driving the cancer. But when we're thinking about staging, because staging is also incredibly complex and complicated nowadays, what other diagnostic tools are you using to see whether or not the cancer might have spread outside of its, OG location?
Once we have a diagnosis of lung cancer, then the most common staging tools that we have are PET-CT, So diagnostic CT scan of the chest, first of all, is very effective in looking for lymph nodes, looking for nodules in the lungs, even looking for spread to other organs like the liver or the adrenal glands. But PET-CT can look for bone metastases more sensitively and other metastases that may be hiding in the background. So I think CT scan and PET-CT are complementary. There's often an assumption that PET-CT is just the best. PET-CT sees everything. Why aren't we doing PETs all the time? CT scan can see a millimeter or two of cancer in the lungs, whereas a PET-CT can only really see a centimeter of cancer in various places. It just takes that much tumor in order to radiate to be able to pick it up on the detectors around a patient. So CT can be more sensitive. Both CT and PET are not sensitive in the brain, and the brain is one of the places that lung cancer can go. So an MRI with IV contrast is necessary, even if a PET says no brain metastases. So those are really the staging to look. And lung cancers, even though many of them stay in the lungs, fortunately, and the lymph nodes, they can metastasize anywhere in the body, many of the places that I mentioned.
Yeah, and I love talking about this because I think it's so important, because quite often these upfront diagnoses are not necessarily done, and someone might be mistaken to have an earlier stage disease when in fact, had we maybe looked a little deeper or a little further, we would have found that maybe a different treatment approach would have been more appropriate. So definitely things to talk to your healthcare providers about.
There are some lower limits, though. 1 to 2 centimeter nodule only in the lungs. It may be okay not to do an MRI. PET-CTs and MRIs are usually done, for 2 centimeters and above, but there are some lower limits.
And small cell, correct me if I'm wrong, Dr. Neal, but small cell also tends to like the brain quite a bit, right? So most small cell,
Small cells, much more rapidly growing cells than non-small cell overall. So, its doubling rate is much faster. And as a result, it oftentimes, grows more in the lymph nodes than it did where it came from when we first see it diagnosed, and it spreads to the brain a lot. So it's unusual to find a small cell that's 1 or 2 centimeters. Even if somebody at risk got a CT scan every 6 months, you might not even see it evolve because it grows so rapidly.
Yeah. Crazy. Okay, I want to move into treatments, and I want to start with early stage because I think that's where a lot of changes have happened over the last couple of years, and how we're looking at earlier stage disease, particularly as it pertains to biomarker testing. So can you talk a little bit about these stage 1 and 2s?
Sure. So, generally stage 1 is lung cancers under 4 centimeters without any spread to the lymph nodes. And stage 1 lung cancers are generally treated with surgery. Although if somebody isn't a surgical candidate, very high dosed focused radiation, there's a lot of brand names, but the general term is radiosurgery, right? Such intense doses of radiation that they eliminate, in theory, 100% of the cancer cells in a particular spot and don't have a lot of radiation around. And that radiosurgery can be done over a couple of days. So surgery or radiation for these stage 1s, presuming that they haven't spread to lymph nodes. Stage 2 is slightly bigger tumors, 4 centimeters or bigger, or spread to lymph nodes. And lymph nodes can be either in the lung, or they can be like at the edge of the lung where it's draining into the vessels, or they can be between the lungs. That makes stage 3. So for stage 2, surgery, but sometimes if we know it's already spread to lymph nodes, we'll want to give treatment up front, or treatment out back for sure. And that treatment can be chemotherapy, and for appropriate patients, immune therapy, or occasionally targeted therapy. So when we think about the treatment of advanced lung cancer, we're using the same tools, but we're bringing them into the earlier stage setting here. And so, for example, immunotherapy doesn't usually work in patients without a smoking history, with targetable alterations. So we don't use it very much, but sometimes we do use targeted therapies in that situation. So, even with an adenocarcinoma, it's like now we have 12 different kinds of non-small cell lung cancer. It's almost like different diseases in the way we think about it. And each one is unique. Generally, stage 1 and 2, surgery, with stage 2, additional treatment, chemoimmunotherapy, sometimes pill therapy.
Yeah, and I think some of these approvals, particularly in the post-surgical setting are very newly approved, and there's a lot of work still happening in that pre-surgery, post-surgery space. A lot of people still looking into outcomes, because we also know with some early stage surgical patients that the recurrence rate was still high, and I think that's why people were looking into it. Like, we think we got it all, but we didn't, so will people do better with some sort of intervention either in the pre-surgical or post-surgical setting? And the data, in some instances, not all, like I said, they're still looking into all of it, it has shown to have better outcomes. And it's interesting when I think even about my own mom and her experience back in 2003, although she had her surgery in 2004, she had both what's neoadjuvant or before surgery and adjuvant therapy, which is after. She had both. So she was treated in both settings, but chemo radiation up front, then the lobectomy and the repair to her aorta, and then I guess, it's actually a good question, Dr. Neal. If they did intraoperative radiation after the surgery was done, is that considered adjuvant, or is that just, I don't know. Like, I don't even know how you classify that, but that's what she had. And a whole lot
I
of.
don't think we do that. We don't do that much anymore.
Yeah, well, this was 2003, right? So.
I don't know what it's called.
Yeah. Yeah.
Brachy therapy.
Yeah.
Trying to get rid of margins and things
Yeah.
like that.
Yeah.
So, I do want to point out immunotherapy, it works great against some tumors, in the advanced setting and in the same tumor characteristics in the earlier stage setting, right?
Yeah.
So, and I think we've really seen advances. Most of the advances over the last couple of years and most of the approvals have been immunotherapy first, after chemotherapy, after surgery, then moving together with up front together with chemotherapy to try and reduce tumors. Yeah. Generally, though, the most important thing is to see a surgeon before doing this, because the surgeon needs to decide, do I want to take you to surgery, or is that probably not going to be a great idea? Surgeons don't say we can't do surgery. They just say the risk is high, right?
Yeah.
When surgery is very high risk for whatever reasons, we have alternatives to cure lung cancers in any stage, including radiation and sometimes chemo and sometimes other treatments too.
Yeah. And for anybody who's watching who might want to take a deeper dive, if you were diagnosed at an early stage as a surgical candidate, we had a thoracic surgeon, Dr. Jeffrey Vallata, come in and talk specifically about early stage disease surgery. We talk about radiosurgery. He's obviously a surgeon, but he did dig into the different types of radiation therapy that can be provided when? June of 2024. So you can go to our YouTube channel if you want to take a deeper dive into the early stage, because that's all we talked about. But I am trying to be mindful of time, and I do want to jump into late stage, which is where also some really exciting things have happened over the last couple of decades, and talk about, we keep circling back to this biomarker testing, and that's early stage and late stage non-small cell lung cancer diagnoses. What's happening in later stage disease where surgery is not an option?
From my own history, it was 2004, I think, when I first got interested in lung cancer, and that was when we started, when erlotinib got approved, but it wasn't approved for EGFR mutant lung cancer. It just got approved for all lung cancer, and there were a few patients who did exceptionally well. We're like, why was that? And they described EGFR mutations. Really, the standard of care in 2004 was maybe get chemotherapy, ever, maybe not. Mm-hmm. And if you did awesome with chemotherapy and you wanted some more, there were some bad chemotherapies that you could get later. Mm-hmm. But not much. And then there was this weird pill that worked great in 10% of people and didn't really work that well in 90%. And that was kind of it for advanced non-small cell lung cancer back in 2004. Yeah. Since then, we had the EGFR mutations identified, a number of pills like shrinking cancer in ways that had never been seen with chemotherapy. That really was identified and proven in 2009. And then we had the ALK story happening in 2008 to 2010 of this big gene rearrangement, very different, which was highly sensitive to a totally different set of pill therapies. And now we have 6 approved pill therapies for ALK. Another one a couple of weeks ago got FDA approved that we actually did work with. Ensartinib, we prefer the name, and I know some of you out there know it well. X396 sounds really cool, right? So that got approved. Is it better than other ones? It's got different characteristics. I wouldn't say that it's the best, but it's another option, and it's highly tolerable and has other interesting characteristics too. ROS1 lung cancer, MET positive lung cancer, HER2 positive lung cancer, like all these advances for these 11 different alterations, including up to the minute. Now we have a recent FDA approval for NRG1 positive lung cancer. And NRG1 positive lung cancer signals kind of through the EGFR pathway and can be inhibited by antibodies that are working on that general pathway. We got a new approval recently.
Yeah, and I think this is what I'm talking about, and where I started this conversation earlier tonight. Just because you knew something yesterday doesn't mean you know it today. Like, that's how quickly things are happening, and that's why the only way we can know whether you might qualify for some of these exciting things that are happening is if the biomarker testing is happening up front, ensuring that we are taking a deep dive look and personalizing this for you, looking at your, I hate to call it your cancer, but looking at the cancer that is specific to you and not just generalizing. And the only way to do that is from what we're talking about and making sure that these upfront diagnostics are happening and that they're also happening at progression, right?
Right. So a lot of times, and I'll just back up for a second because I did have a patient reflect on the your cancer thing one time. I said something about your cancer. She goes, "This isn't my cancer."
Yeah, that's right.
We'll call it that cancer.
Yeah.
Right?
Yeah.
It just happens to be riding, but it's unwelcome.
Yeah. Exactly. Exactly.
Yeah. So that cancer can be treated by all kinds of things. Yeah. So we hope every treatment, even in the advanced in the stage 4 lung cancer setting, works forever, right? Literally, like, it's the best thing and it works for a long, long time. Unfortunately, these treatments, sometimes even when they work really well, some of the tumor cells figure out how to survive and grow out, and they're different. They're different genetically than the original ones. So after targeted therapies, when we're really hitting that pathway, when we're hitting that driver mutation, the cells that survive, by definition, are ones that somehow got around our inhibition. And there's many different ways that they can do that. Some of them we understand, many of them we probably don't right now. And so that's why we think about another liquid biopsy or a repeat biopsy when there's been a great response to a targeted therapy and then tumor emerges again. Yeah. After immune therapy, like, tumor sometimes goes away, like, forever, and you can stop the treatment even in stage 4. It's unbelievable. I have a few patients who are fortunate enough to be in that position and stopped immunotherapy, and it just didn't come back. Somehow the immune system completely eliminated it. For targeted therapies, though, we think we're always suppressing a small population, so it's good to continue them as long as they're working.
Yeah, it's so interesting. We've got some folks in this room tonight who those very things have happened for, and it's mind-boggling and fascinating, and, like, unlocking that key could answer so many things, right? Like, how and why does that happen for one, but maybe not all. So we've gone through, again, at very high level, this sort of overview of a lung cancer diagnosis and treatment. We will be digging into a lot of these things that we talked about throughout the year, taking more time to discuss each sort of point that Dr. Neal talked about today. But one of the things I think is important to talk about, because we talk about it a lot, is a multidisciplinary team. Can you tell folks watching not just what that is or means, but why it's important to them?
Well, it's just fun to say the word multidisciplinary in the first place, right?
Yeah.
And basically what it means is everybody who knows an area fairly well gets together and thinks about all together what should a treatment plan be. All from diagnosis, all the way through let's try to cure this often. So in the earlier stage setting, we have tumor board every week with pathologists, PET specialists, CT specialists, a surgeon, sometimes more, a radiation oncologist, sometimes more, and then a bunch of other people, a bunch of medical oncologists usually there. What tumor board is a good way for all of those brains to come together and think about somebody. Tumor board is not a review of a case for 30 minutes. Tumor board is a question, right? Let's answer one question, review everything together. Should this patient have surgery? Or do we think radiation is a better idea based on it, as opposed to the patient going around and shopping around and seeing all of these different doctors? Having everybody making a joint decision together is important. So, I think the key players in a multidisciplinary team are the surgeon, right? They're the only ones who can say surgery is a good idea or maybe not, as well as radiation oncologists and medical oncologists. We have pulmonologists as well. So, that's what makes up a multidisciplinary team in thoracic oncology. I will shout out our newest friend is AI. So I've been toying around with using AI tools, private secured. Don't worry if you've been discussed the tumor board, but we copy and paste a few notes into the AI and then say, like, can you please summarize this patient and outline the tumor board questions so that we can all focus a little faster?
Yeah.
Because 3 minutes a patient is kind of hard to focus.
Yeah. No, you're not wrong. And AI, we'll have another living room meeting about that and the way it's impacting healthcare in general and benefiting healthcare in general, but also addressing concerns from the patient populations, because I know those are there. But the bottom line when we're thinking about multidisciplinary care teams is you're basically getting a comprehensive collaborative decision making, right? And I would love to think, and I know this does happen with Dr. Neal, that patient goals are kept in mind. So when healthcare provider XYZ is bringing, case X, Y, or Z to the tumor board, the doctor sort of spearheading that is keeping the goals of the patient in mind, right, when they're having this conversation. So unbeknownst to you, this is happening. If you're saying I absolutely yes with this or I absolutely no with that, and surgery is a perfect thing. Like, I don't want surgery, so maybe I want to consider radiosurgery because I'm not interested in going under the knife or general anesthesia or the recovery or any of that. Those types of things are kept in mind when going to tumor board.
And that's why AI will never make the decisions for you.
Correct.
You need somebody who understands, what are all those other factors? How far do you drive? Who are you taking care of? And who's taking care of you? All of those things have to be factored into any decision,
Yep.
right?
Absolutely.
And but understanding, the context and distilling it, it's been an effective tool.
Yep. So outside diagnosis, treatment, all these what good look like things that happen, people also need other forms of support. I want to talk a little bit about that. One in particular for you, Dr. Neal, is palliative care or side effect management, and what an important role that plays in somebody's experience.
Yeah, so no treatment is without side effects, right? And so sometimes people wonder, like, how does my quality of life improve by getting a treatment like chemotherapy? Yet it does on paper, because we look at quality of life over a period of time. We don't look at quality of life just today. And if you live a longer period of time, generally, hopefully, you have a better quality of life over that period of time. So palliative care doctors, there's older data. Actually, it was conducted while I was a fellow in MGH. Seeing a palliative care doctor early referral to palliative care helps you live 2 months longer when you're diagnosed with lung cancer. And hopefully you live better. So we're trying to do both at the same time. A lot of symptom management from therapies is on the oncologist and our team, and I have to recognize my team. I can't do this alone. Our team of nurse practitioners, physicians assistants, nurse coordinators who are constantly on email and communication with patients, as well as everybody else who's part of the team, right? So we're all managing side effects. Sometimes people are stuck with worse side effects, really hard to manage ones, and I think palliative care can be great. To help have a confidant to say, like, let's really drill down and feeling better, while the oncology team is also trying to help us live longer.
Yeah, I agree. And I think there's a gross misconception about palliative care being the same thing as hospice care, and it is in fact not the same thing. And I believe, I hope I'm not wrong, but Stanford just recently opened up a whole palliative care center, correct? Did that happen? Am I making that up?
We have hospital beds that are more noted toward palliative care.
Okay.
I don't know if we have a center, but we have excellent palliative care physicians and teams that we put in referrals, mostly see people by video.
Yeah.
So, the old days it was like they'd have to chase people to infusion and sit there at chemotherapy because
Yeah.
we're out of rooms and people are like, I'm on short time here. I think video visits have been great for palliative care though.
Yeah, I love that. And last but not least, well, this is actually second to last but not least, second opinions, because people ask us about this all the time. They're like, oh, I saw Dr. So-and-so talking and I'm not receiving this. Like, this is not what I'm getting from my healthcare provider, and how can I either have a conversation with he or she and or get a second opinion? I know you do. I know we refer people to you for second opinions all the time. What are your thoughts on second opinions and when someone should seek one out?
What I've found is sometimes people are sort of scared of getting a second opinion. So my patients go elsewhere, who I've primarily treated, and go to other places and get second opinions. And I support that because I want to know what other doctors are thinking. Sometimes it's nice to have a fresh review of everything. And so whether somebody's being treated in the community, where their doctor may have a lot of expertise with lung cancer, but it's not all they do with access to clinical trials, or somebody who's treated at an academic center and wants to just like have everybody double check everything and say what out there, what are we not thinking about? We support second opinions, and very few, less than 1% of doctors would be offended if their patient got a second opinion. That's the main thing. We want to help you, okay? And if there's 2 doctors, like maybe we can help you more. If there's 7 specialists, that might be too much. So there can be a limit,
Yeah.
I can tell in my computer record most of the academic places that share our medical record and where people have gone. You don't need to go to 7.
Yeah, no, I couldn't agree more. But what I can agree with is if you are talking to your current healthcare provider and requesting a second opinion and they do get upset about it, in my opinion, it's all the more reason to actually go and get that second opinion. Because to Dr. Neal's point, he's not offended. The docs we have on here where we talk about second opinions, they're not offended. And an even bigger point that he made is now you've got more than one person looking at your case together. So I think it's important.
I will point out that somebody's got to be in charge and somebody can be a consultant, right? So
correct.
If somebody comes to me and they're like, are you double checking every dose of chemotherapy that I'm getting? And I'm like, no, at the end of the day, you can go and look at 2 menus from restaurants, right? And you can ask the chefs to share recipes, but you got to eat at one restaurant. You can't keep walking back and forth across the street and splitting meals.
Yeah, I agree. I could not agree more. Joel, what do you most hope people take away from this conversation tonight?
The advances in lung cancer have been tremendous beyond what I might have anticipated as an intern 20 years ago. I was just thinking about hey, this is a cool field and there's a lot of interesting things to learn. I think we've now unlocked so many mysteries of lung cancer and open the door to even more things that we can find to get better at boosting the efficacy of immunotherapy. I do want to mention one thing, I think the most exciting approval this year was actually in small cell lung cancer with this new drug tarlatamab, which is a novel therapy in all of cancer. It's bringing the immune cells directly to the cancer. It's instead of PD-L1 getting rid of the shield, this is hey, you, immune cell. Hey, you, cancer. Go talk to each other, right? Yeah. It's like a forced introduction. Yeah. So I think tarlatamab is really cool, and seeing things like that, I'm really excited about.
Yeah, me too. We do have at least a couple of year small cell lung cancer specific meetings where that's all we talk about. So we talked about Tarla before it was approved. We've talked about it since it's been approved. We too find it very exciting. Anything new that's happening in small cell is incredibly exciting, although it's the least common or less common type of lung cancer to get. It still affects a whole lot of people, and there hasn't been nearly as many advancements made to treat people with small cell lung cancer, and this one is incredibly exciting. I agree. Well, I want to give a huge thank you to Dr. Neal for stepping in for Dr. Salgia. as always, it's a pleasure talking to you. If I don't see you before, hopefully I'll see you in Chicago at ASCO. As you're just always so insightful, and the way you were able to bring this high-level information to our community, I could not appreciate it more. I know I'm seeing a lot of head nods in the room, and I'm sure people are nodding their heads at home. So thank you so much. And until next time, we appreciate you. We appreciate you.
Thank you for inviting me back to the living room.
Yeah. I do want to remind everybody about the text to remind. If you're not signed up for text reminders about this programming, you can do so. I think it's going to come up on the bottom of the screen for those watching from home, and we've got the number here for anybody in the room who's interested in those reminders. You can say stop at any time if we get annoying, but I don't think we're annoying. Again, huge thank you to Dr. Joel Neal for coming out and talking to us tonight. For all of you in the room, those of you watching live, those of you who watch post live, Penn Media for coming in and setting up this equipment in the war room in the back every month. Huge thank you to you guys. Michelle Zay, who is over there in the corner moderating all the chat online. And of course, our supporters, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda Oncology. We could not bring this programming to our patient community were it not for you. So thank you all so much, and we will see you in February.
Thank you.
Thanks, guys. Thanks, Joel.
So I'll be brave if you're brave. I'll be brave, but only